Today, we are discussing an important topic regarding screening for hearing in newborn babies or hearing assessment in newborn babies. We will be particularly discussing 136 rule. First of all, as you we all know that incidence of significant hearing loss is around 1 to 3 per 1000 newborns, and the risk is higher in newborns who got admitted in NICU at birth or got admission in neonatal ICU in neonatal age. So what is the significance of hearing assessment? As we all know that hearing loss has a significant impact on development of number one speech, number two language, and number three cognitive skills of a child. So early intervention remains key here. It is being said that early intervention may be in the form of hearing aids, implants, rehab, rehabilitations, results in number one, almost, or you can say normal, near normal hearing. Number two, good acquisition of speech and language, and as a result, there is normal, or you can say good school performance. Now, what are the recommendations? Indian Academy of Pediatrics and American Academy of Pediatrics both recommend that there should be universal neonatal hearing screening. But unfortunately, it has not been uniformly it has been not uniformly attained in all states of India. And in most developing countries. So to get these children with hearing assessment with hearing loss, to get them early and to have early intervention, there's a rule called 136 rule. That means all newborns screening tests for hearing should be done by 1 month of age. By three we mean those who fail in screening tests, secondary diagnostic tests, or confirmatory tests should be done by 3 months of age. And those children diagnosed with hearing loss should be treated by 6 months of age. So this is the rule of 1, 3, and 6. Goal being early intervention so that the baby has normal language and speech, normal social development in future, normal physical development, and normal school performance. Now we have some screening tests and definitive hearing tests. First of all, we run these screening tests, and when the child fails in screening test, we go into the definitive tests. Among the screening tests, we have Otoacoustic Emission, Otoacoustic Emission, and we have Automated Auditory Brainstem Response, where we keep electrodes on the scalp, measure brainwave activity in response to sound played through earphones, checking the nerve pathway, and in autoacoustic, a probe in the ear plays sounds and measures tiny echoes, that's vibrations from the inner ear's hair cells. No echoes suggests hair cell damage. And if the child fails, we go to the definitive tests, and among definitive tests we have visual reinforcement audiometry, done in children between 6 and 24 months of age, where we where these children they turn towards sounds to see a visual reward like a toy lighting up. And then we have conditioned play audiometry. It is done in children more than 2.5 years. Then we have pure tone audiometry. It is standard for older cooperative children. They indicate when they hear tones, that's beeps, via button press or spoken response. It's done in older children who are cooperative. And then we do tympanometry. Tympanometry checks middle ear function by changing pressure in the ear canal. And then lastly, we do bone conduction tests, where a vibrating device bypasses the outer and middle ear to test the inner ear directly, helping identifying the type of hearing loss, whether it is bone conduction loss or that or simply conduction loss or sensory neural hearing loss. Thank you for your patience. I am Dr. Nasir signing off.